Okay, so we're going to look at the pathophysiology of the airway. What's pathophysiology mean? That's the disease process. So we're going to be looking at not just the normal airway, but the problems with the airway, disease process or injury. Probably one of the most important things we're going to get out of this chapter is recognizing an adequate and inadequate airway. Now, what exactly is an airway? Yeah, that's going to be the path that the air takes in and out of the body. That's going to be the airway. So breathing is something different than airway, right? Breathing is what? Yeah, that's actually the movement of the air. The airway itself is just static. That's going to be like, you know, I-85. It's just the road. But our breathing is going to be when the road is really populated. See what I'm saying? So there's really two different things there. So the airway is going to be is the path available, and then the breathing is it being used? We're also going to look at how to open an airway, maintain an airway, how to use the airway adjuncts, which we did the other night, and techniques of suctioning, which we also did. So some of the stuff we've already covered, which will help us move along a little bit more quickly, but hopefully it's going to give you a little bit better background when we're talking about some of this stuff. Okay, we talked about the upper airway. What exactly is the line of demarcation for the airway when we talk about upper airway? You know what line of demarcation is? That's going to be the line that marks the upper from the lower. The line of demarcation would be what? The larynx. What did you say? It's really the larynx, which is a kind of a large thing. So if you got something blocked in the lower part of the larynx, that would be considered an upper airway. But anything below the larynx is considered lower airway. So we talked one day about what the mouth and the nose does for us, what they do for us. Remember what those things are? We did the same thing, so let's see what we can remember. We breathe air in through the mouth and the nose. What are those structures doing for us, besides providing a passageway? It warms the air, humidifies the air, it filters the air. Good work. And all those are important. Of course, we know about the filtering thing, but warming it, humidifying it makes it much more comfortable for us to use the air. You know, if you go outside on a really cold day and you breathe in, it makes your chest hurt. Yeah, it's too cold to go in there. Or we talked also, for those of you that have had oxygen on before, if it's not humidified, it dries you out and it's very uncomfortable. The pharynx, we actually break the pharynx. What exactly is the pharynx? It's a space. The pharynx is just a space behind the nose, behind the mouth, above the airway, above the glottic opening. That's the pharynx. So the oral pharynx is going to be behind. Oro means mouth, behind the mouth. Nasopharynx, behind the nose. And the laryngopharynx really is the area right where our larynx is. Sometimes you may see a hypopharynx. A hypopharynx is going to be the bottom part of that open space before it moves south. So the upper airway, actually, here your book says it ends at the glottic opening, but most commonly we think of the bottom of the larynx as being the end of the upper airway. I'm not going to put that on test, but kind of know that above this point is the upper airway. If I said, if you hear wheezing, is that an upper airway sound? You would say, no. Good. Okay, here we go. This is the same picture we saw the other day. We've probably seen it a couple times by now, all our spaces. The laryngopharynx is right here, just opposite. Here's the epiglottis. So the laryngopharynx basically is the hypopharynx in here. The vocal cords as you move south below the epiglottis. Remember the cartilage we talked about here? What's our top cartilage? Thyroid cartilage. What is the membrane that's next? There's a little space. The what? The cricothyroid membrane. And then below that is going to be what? The cricoid. That's right. What did I tell you specifically about pediatric patients and the cricoid cartilage? It's the smallest part of the pediatric airway. That's right. Just wondering if you were paying attention. I think I mentioned to you about the hyoid bone. Did I talk about that in this class? One of the other classes? That must have been the paramedic class. The hyoid bone connects, the tongue connects to the mandible, but also the hyoid, I can always say that tonight, attaches at the epiglottis. So when you bring the jaw forward, when you're doing the jaw thrust technique, when you bring that jaw forward, you're opening the epiglottis, which what happens when the epiglottis opens? Okay, what happens when it closes? Nothing. There's no breathing taking place when the epiglottis is closed. It's like, think of it like, you know, the big trucks that have those little air horns. They go, and that little flap goes up and down. When the steam is going out, is it open or closed? It's standing up, so you've got air motion there. Same thing with the epiglottis. Okay, what can interfere with airflow in the upper airway? In what way? I don't even open my mouth. Yeah, if you got a traumatic injury here where it damaged it, crushed it, or say a knife through there, that can interfere with your airway, your upper airway. What else can interfere with that? Food, yeah. If you got a blockage in there, you choked on something. What else?
Swelling.
Yeah, if, say you get stung by a bee, and so you're going to get laryngeal swelling through here, certainly. Yeah, so those are probably the main things, something of those type. For the lower airway, the book says it begins at the glottic opening. We really think about it more a little bit lower below that, but still you've got a wide space of lower airway, from right about the larynx all the way down to the end of the alveoli. So you've got the trachea. The trachea actually begins below the larynx. The bronchial passages, those are going to be your big bronchi that end in the alveoli. It's a picture of the lower airway. Can we talk about this muscle area here at all? This is the shape of your trachea. And this is a cross section of it. So this is pretty firm cartilage around here, but at the back, you've just got smooth muscle tissue. Why is that important? What does that do for you? Think about it. Right here, we've got our hard C-shaped cartilage at the front.
Expand and contract.
Yes, and why is that important? Because that's what smooth muscle does. That's good. Why would you need that too? To be able to be flexible?
Your esophagus is behind there.
Yeah, and that's good or bad.
Sometimes needs to expand.
Yeah, so your esophagus is soft tissue, and it's going to be behind there. So if you, this is kind of one of those, have you ever swallowed something too big, and it's trying to go down the esophagus? I know, none of you guys have ever done that. And you can feel that going down, and you can't breathe while it's going down, even though it's in the esophagus, right? But part of what happens is it's moving down the esophagus behind this. It allows it to intrude on this so that it's able to pass on down. So it allows some flexibility there, which in most cases is pretty good. What did I tell you is this point where these two split apart? That's the carina. And when they split, what do we call that? Bifurcation. It bifurcates right there. And then as it gets, the trunks get smaller and smaller and smaller until it gets down to, to the alveoli. Okay. At the alveoli, I think we've already talked about this, those are tiny little sacs. They almost look like a cluster of grapes in there. And if you split open a grape, a real grape, and you spread that out, you would see it really appears to be much larger than just a little grape. And that's what's happening with the alveoli. You have so much surface area on each one of those little cylinders that it leaves a lot of space for gas exchange. If you laid out all the tissue of all the alveoli, I think I read somewhere that would cover like 3 tennis courts or something. It's just this massive amount of area that's used for gas exchange. And that's important because later on we're going to talk about pathophysiology, disease process in the lungs. So anything that interferes with that surface area on the alveoli, what's going to be the consequence of that? Okay, I have these alveoli, and all of a sudden they're all beat up and aren't working anymore. What's going to be the consequence?
Left air exchange.
Yep, poor gas exchange. You're not going to be able to exchange as much gas as normal, so you're going to have respiratory problems. Each alveoli is surrounded by capillary beds, and that's where the gas exchange occurs. Now, think about this. This is my alveoli, one of them, alveolus, I guess, and these are my capillary beds surrounding there. Say I had a disease process. Say I built up a lot of mucus in my lungs, and the mucus got inside here between the capillary beds and made my alveoli. What's going to be the consequence of that? Same thing, don't you think? Poor gas exchange. That gas is going to have a hard time moving through all that slobber in there, you know, that mucus, whatever it is. So that's going to interfere with gas exchange. So that's why it's important that you understand the physiology of the alveoli. So the oxygen is on which side of this whole deal? Is the oxygen on the capillary side, or is the oxygen on the alveolar side? Yeah, because the oxygen is coming in, we're breathing that in, right. So, but they're going to diffuse across, hopefully they're very close, and the diffusion will occur effortlessly. Did I say that right? So we're going to move, by diffusion, carbon dioxide into the alveoli and oxygen across. And we call that gas exchange that occurs at the alveoli level is called what type of respiration? It's a vowel. Do what? No, but I appreciate the guess. External ventilation, or external respiration, when it occurs at the capillary beds at the cellular level, it's called what? Internal. That's right. I know you'll need to know those. Okay, airway obstructions. We talked about this just a minute ago. There can be a variety of reasons or types of things that can interfere with that gas exchange across the alveoli. Foreign bodies, food, inhaled objects, liquids, blood, vomit, mucus. Obstructions may result from poor muscle tone caused by altered mental status. What would that mean? What are we talking about there? Poor muscle tone caused by altered mental status. What is that? Remember I talked about tone the other day, and I do remember talking about that in here. Your muscle tone. Like right now I have reasonable muscle tone because I'm moving my body around. You guys have a little bit less muscle tone because you're barely just holding your heads up. Yeah, possibly if you had a stroke where you could not control your muscles at all. If you were unconscious, remember we talked about dead weight? When a person has no muscle tone at all, where they're not controlling their limbs in any way, it's like dead weight. That's poor muscle tone. So say you're laying on your back like this and you're unconscious. Can you think of anything that would have poor muscle tone that could interfere with your breathing? Yeah, that big old fat tongue will fall back there and obstruct your airway. So that would be an example of poor muscle tone. As long as you're alert, you're going to keep your tongue away from the back of your throat, aren't you? As long as you're sitting here, you're going to notice right away if that old tongue drops back, or the rest of us are going to notice because what's going to happen? You're going to start snoring. We're going to talk about you. So yeah, if you're unconscious or semi-conscious, you may not be able to control that tongue because you've got poor muscle tone. So that's an important thing for you to understand. Okay, other airway obstructions? Yeah. It can be, we can have an acute airway obstruction or a chronic airway obstruction. What does acute mean? I don't mean it's really good looking, but what?
Immediate.
It's immediate. It's just happened like you're talking and all of a sudden you start to choke on a piece of steak. That's acute. Whereas a chronic airway obstruction might be something you constantly deal with. Say a patient with COPD, chronic obstructive pulmonary disease. These are patients with mucus that builds up around the alveoli. These are patients who alveoli break down and they lose the surface area. Those are people that have airway obstructions that would be considered chronic. So you're going to have to evaluate your patient's airway. And one of the things you're looking for is, do they have the ability to maintain an open airway? If you've got a patient that initially is maintaining their own airway or maintaining a patent airway, we've talked about patency in here, haven't we? A patent airway means it's clear and it's maintainable. So all you guys in here, you have a patent airway. And I look at you, your eyes are open, you appear to be breathing for the most part. Pulses look like they're all intact. So you're maintaining a patent airway because you can do that on your own. A patient who has a lot of swelling in the airway, say they're having an allergic reaction, their airway might be patent this minute, but 5 minutes from now it may not be. So you may have to make the determination about whether your patient can maintain their airway or not. So that would be patency. So you're going to monitor the patency or the ability of your patient to keep an open airway over a period of time, over the period that you have your patient. So just because the airway is good right now doesn't mean it's going to be good 5 or 10 minutes from now. So you're monitoring for patency. Said acute foreign bodies, vomit would be acute, blood, edema from burns, trauma, infection. Those are something that kind of builds up possibly over time. Patient with a decreasing mental status, they may actually occlude their own airway with their big old fat tongue. Okay, other things that can cause airway obstruction, we briefly touched on bronchoconstriction the other day. Broncho we know is what? The bronchus, that's going to be the major branches of the tubes in the lungs. And when they constrict, what makes them constrict? What is it? What's the physiology then that makes them constrict? What is the body part that makes them constrict? What's the muscle tissue that makes them constrict? Smooth muscle tissue. I knew we'd get there eventually. Smooth muscle tissue. Bronchoconstriction is going to be lower airway, right? Smooth muscle constricts, closing off the diameter of the airway, so you can't move as much air. Okay, airway assessment. We're going to start looking at our assessment sheets. You have a trauma assessment sheet and a medical assessment sheet. And the top parts of both of those sheets are almost identical. So we're going to start learning those sheets probably by Thursday. And in the primary assessment, we're looking at airway, breathing, and circulation. When we get to the secondary assessment, we're looking at broken body parts, broken bones, that sort of thing. So in the primary assessment, we're looking for what's going to kill your patient that regarding A, B, or C. A is airway, B is breathing. So 2 questions we're going to want to know immediately in our initial assessment, which would be initial assessment would include our airway assessment. Is the airway open and will it stay open? That's what patency means. Is it open and can the patient maintain it? If the patient can't maintain it, you're going to have to maintain it for them. But patency is the key terminology here that I want you to understand. I don't need you to identify it by writing out the definition. I want you to understand it and kind of soak it into your brain, okay? Thank you for coming back. I like this picture, so I'll put it in here. Will the airway stay open? Now, does anybody have any idea what these are pictures of? Yeah, these are your vocal cords. This is you breathing. The vocal cords are open. These are your cords actually here. This is you not breathing with the vocal cords closed. Now in these pictures you can't see the epiglottis because it's up here somewhere. When they're taking this photo, this is during a live intubation and somebody is actually holding that epiglottis open so you can see this. Same thing here, the vocal cords are open when you're breathing, closed when you're not breathing. They push closely together to keep fluids and other objects from going down there. So we're constantly observing and evaluating the patency of the airway. Is it open? Is it going to stay open? What are we going to have to do to fix it? Okay, one of our jobs in the initial assessment is going to be recognizing any airway problems. So these are things that may indicate to you that the patient possibly has some airway issues. If you walk in and you ask a patient what's going on and they're going, what's that? Yeah, it may be I'm choking, I can't breathe. How long are they going to stay like this? Not very long. What's going to happen to them? Yeah, done fell out. They're going to go down pretty quickly. If they have an inability to speak, then yeah, you're going to assume choking and act on that. If they have a a raspy quality to the voice. Now, some people naturally have a raspy quality, but this is like the real rasp, where there's some swelling in there. They may have an injury or a blockage of some sort. We see this more commonly with inhalation injuries, like a firefighter that's inhaled some superheated gases and it starts to swell. You get edema in there. It may sound very raspy as they talk to you. And we'll talk about other indications of inhalation injury later. Stridor, I've highlighted this, or bolded it, if you will, because it is an upper airway sound. It indicates an upper airway obstruction. Stridor is kind of a high-pitched sound, and if y'all will remind me, I'll play those for you here in a few minutes. And Wednesday night, tomorrow night, we will listen to different airway sounds. We've got a little sound producer thing that we'll use. But stridor is an upper airway sound. It indicates a problem or obstruction or blockage in the upper airway. So just identify stridor, upper airway. Stridor, upper airway, okay? Snoring also is an upper airway sound, but snoring is usually due to the tongue blocking the airway. You know, if you're laying down, you know, and your tongue drops back, you're going to get that snoring thing going. I'm sure y'all have never heard anybody snore. Not loudly anyway. Gurgling also is an airway, upper airway sound. If you hear gurgling, that's going to indicate what? Fluid in the airway. And if you walk in and somebody's gurgling, you know, they're unconscious, and you hear this gurgling sound every time they breathe, what are you going to want to do? Yeah, the big S word, suction it. You want to suction it immediately. Okay, other signs of an inadequate airway. By inadequate airway, we mean that the route is not open. Anytime there's foreign bodies in the airway, if you can't see or hear any air moving in or out, you've probably got a blocked airway. So like if you look, listen, and feel, remember we did that when we were ventilating last week. If you'll look at the chest rise, you'll listen to see if you hear any air movement. You may be able to feel some air movement. So if you don't, they're not exchanging any air, then guess what? They have an inadequate airway, right? If you don't see any chest movement, if you look at their chest and there's no movement, well, it's possible they may be breathing a little bit, but they're not breathing enough to sustain life for any length of time. That would be an inadequate airway at least. Abdominal breathing, if you see the abdomen going in and out in an adult, that's a sign that there's some kind of issue here. You could have a patient possibly with a spinal injury or a chest injury, and they're not able to expand their chest, so they're using their diaphragm to move the airway. And we mentioned earlier any changes in the quality of speech, you know, if it's raspy or that sort of thing may indicate inadequate airway. What is the most common foreign object on which adults choke? Foreign object. Would the tongue be a foreign object? I hope not. Do I have it on there? Do what? Toys? For adults, I'm pretty sure it's food. Differentiate between a partial and a complete airway obstruction. How can you tell it's a complete airway obstruction? You don't hear anything. You don't hear any air movement. You don't hear them trying to talk. You're not hearing any airway sounds. There's no air moving. How about if it's a partial airway obstruction? How would you know if that was partial or complete? How would you know if it was a partial airway obstruction? They are moving some air. What about a sound? They make some kind of noise. What's the sound I told you a few minutes ago? It's an upper airway sound. Stridor, that's good. Stridor, that usually will indicate an upper airway blockage of some sort, usually swelling, but it's a partial blockage. Stridor must have air moving through the vocal cords, moving through the airway in order to produce that sound. So that's going to indicate a partial airway obstruction. Now, if how would you determine when to do abdominal thrusts on a conscious patient with some type of blockage? Now, if it's completely blocked, they're not moving any air, they are not making any sound, you know, they're going like this and they're starting to turn blue, what would you do? Abdominal thrust, yeah. What if they're going, oh, my throat hurts. I don't know what to do. Are you going to do abdominal thrust? No, they're still moving air. At some point where you don't have to wait until it's blocked completely, but you can tell they're moving so little air that it's going to kill them pretty soon anyway. But as long as they're moving enough air that they are staying of sound mind, you know, not an altered mental status, then you're probably going to want to leave well enough alone. Because if they're moving decent air and you start doing abdominal thrust and now you block the airway, have we gotten better or worse? Yeah, we've definitely gotten worse here. Okay, with pediatrics, with little kids, one thing you will notice with them when they're having respiratory distress, you'll see retractions, meaning you can see the little muscles from inside between their ribs kind of sucking in. You look here and they're kind of going, you'll see that. You'll see nasal flaring with kids. You don't usually see that with adults. You may, but it's not common. With kids, it's very common. Okay, how are we doing so far? What time did we start? I forgot to look. About 6? Okay. Okay, opening the airway. We talked about 2 ways to open the airway last Wednesday night. What are the 2 main ways? Head tilt, chin lift. You need to be familiar with that terminology. The registry, they don't try to trick you, but they may move some of those words around. Head tilt, chin lift. What's the other one? The jaw thrust. And it may say the jaw thrust or the modified jaw thrust. And those are different. However, most places they will use those interchangeably. Which one of these methods will we use for a trauma patient? The jaw thrust. Okay. When the primary assessment indicates an inadequate airway, a life-threatening condition exists. If they don't have, when we talk about airway, remember, that's just the route. So if it's compromised in any way, the patient's not going to be able to breathe well. We're going to have to be very quick about it, managing that. And I just can't tell you how important that is. If you don't recognize that they're having an airway problem, they could die right there, and you're going to feel bad about it forever and ever. So you got to open the airway. If the airway's not open, you got to open it. Now, in most cases, that's one of the things you're going to do. If your patient's unconscious, you're going to open their airway. If it's a trauma, you're going to do what? Jaw thrust. If it is medical, head tilt, chin lift. Yeah, and you're really going to do that before you assess for breathing. You know, if your patient's neck is all kinked up somehow, and you're trying to determine if they have an open airway, are you going to be able to tell, really? No, once you open the airway, then you can tell if it's clear or not, if there's anything blocking it. But you got to give it that shot to open it first and then evaluate it. So it's, older days used to say, head tilt, chin lift, open the airway, look, listen, and feel. So you can't evaluate their breathing until you open the airway. If they're conscious, I hope they're going to open their airway. They maintain it themselves. But if they're unconscious, you got to open the airway and then evaluate. I mentioned to you that with the head tilt, chin lift, as well as the jaw thrust, when you're moving, when you tip your head back like that, you're moving the jaw forward anyway, or you do it manually for them if they can't do it. But that motion, since the epiglottis is attached to the hyoid, since the tongue is attached to the mandible, when all that moves forward, it opens your airway. It's great. Head tilt, chin lift. Now notice the fingers are on the bony part of the chin, not under the soft part. That's not good. Make sure you grab them on the bony part of the chin. Most of your pressure is going to be on the forehead here when you're opening that airway. Place one hand on the forehead, fingertips the other hand under the patient's jaw, tilt the head, lift the chin. Kind of, if you need to use your thumb, just kind of open the mouth up because they're going to be breathing through that most commonly. You know, adults are more mouth breathers, while our children are more nose breathers. The jaw thrust, I think I went through this the other night. Now this guy's using the thumbs here. Remember I showed you a couple ways you can do it. You can use the thumbs, or you can use this part and press down, whatever works best for you. Place your hand on each side of the patient's lower jaw. The angle's just below the ears. Remember we felt that? Didn't everybody feel that? Right here is that point where the jaw turns. That's where you're going to use that to lift the jaw. You want to keep the patient's head straight up and down. You don't want it turned in any way, just straight up. Okay. Now you're going to have to make sure that the patient is in such a position that the airway can remain open. If you do a head tilt chin lift, just make sure that the head stays back. It may be that you have to slide a little towel or something up under the neck to hold that open, so you don't have to worry about that. With the jaw thrust, somebody's got to hold it all the time, and that gets very tiring. If you're having to do a jaw thrust on the patient, you want ALS there so they can go ahead and intubate them, so you don't have to hold that. That's likely. So once you open the airway, you're probably going to have to suction. If they're unconscious, if they've been laying on their back, all those secretions will be pooling in the back of the airway, and they may not automatically swallow. If they're so far unconscious that they won't swallow, then it's going to pool in there, and you run the risk of it running into the airway down the trachea. So you may have to suction. With kids, we open their airway quite differently. You know, their heads are so big, especially at the back part here, that tipping the head back moves their whole body. What we want to do is place a towel up under the upper shoulders here to raise it up so that it compensates for that big old knot on their head, you know, just their big old heads. So we always are going to pad under the shoulders of a little guy, a little kid. We don't want to tip the head back real far. I think I drew this one day because I'm such a good artist. With adults, their airway is kind of, when you tip the head back, their airway's straight. With a kid, when you tip their airway back, you actually kink their airway because it's much more called anterior. So when you tip their head back, you're actually closing it off. You ever use those little Pez containers, you know, with those little candies in there? If y'all act like you never heard of that, I know you're lying. Little Pez container. When you tip that head back, you know, it forces that little piece of candy out. When you tip your kid's head back, it actually closes the airway, like sticks that thing right there and they can't breathe. So you don't want to put their head back. You may put it in a neutral position, like this is pretty much a neutral position. As they get a little bit older, we move to a sniffing position where the nose is just a little bit up. But when they're, you know, from 0 up to, you know, 7 or 8 years old, you don't want to tip the head back because you actually close the airway off. You know, when that Pez thing kicks that thing out, it closes off access to all the rest of the little Pezzies. Whoever thought, what does Pez mean anyway? Okay. Evaluate the need to pad behind the patient's shoulders. Now, we always do that with pediatric patients, but sometimes you may have to do it with adult patients. I had a guy one time that was quite large, but he was very beefy in the back here. And when he laid down, this was so beefy here that his head just went way back. Well, he was a trauma patient. We ended up having a pad up under his head. Sometimes you may have the opposite. If you've got a very small person, their head may actually be larger and they may have to be very thin through here, and it then throws their head forward. So evaluate with each patient to make sure you have neutral alignment. You may have to pad under it, you may not. You may have to pad under the shoulders, you have to pad under the head. So you're going to evaluate each patient to determine how you're going to keep an open airway. This is just a little photo of the kid. Their head is so big back there that this is what you're going to get if you don't pad under the shoulders. Pad under the shoulders, it gives you that nice little sniffing position. His head is in a neutral position, and his airway is going to be pretty open.
Ms. Curry, when they teach you CPR in East Alabama, they teach you to tilt the head tilt chin lift on the babies. Oh, I just had that class. They didn't say anything about keeping your hair straight. It's always the head tilt chin lift. Yes.
Your book didn't say that.
No, but I'm just saying they teach you that here. I mean, well, at East Alabama.
Yeah. Well, that's not correct according to American Heart Association.
They do. I mean, they really do. I just had it like 2 weeks ago.
Do you know who you teach it? I know they bring in people from the
That's
outside.
American Heart Association.
Yeah, that's American. Yeah, and they teach.
Did they tell you that too?
Yeah, I went back to the
Yeah, that's right.
Oh.
You
They said to tip the head back on a pediatric patient?
Not far though.
Yeah, but
But
still,
still
tilt it back.
tilt it
They have
back.
people pulling the heads back pretty far. And
It's just sniffing position. If they're like 7, 8, or 9, then you go in sniffing position where, let me back up here. This is about sniffing position. Now, if the patient's head is like this, then yeah, you're going to pull it back, but just to a neutral position.
I mean, they go through it with you, the baby, you put them on the table, and it's, you hold your hand back, and lift their heads up. We went over that several times, so you might want to say something to them, because that's
Yeah.
what they teach you.
Yeah, unfortunately, they don't listen to us. But yeah, that's definitely incorrect.
Maybe I should call them.
Well, you've got your American Heart Association book. You can look it up, and you can say, hey, it says right here. Yeah. I'm glad you mentioned that. That's something we'll make sure we watch out for. Airway adjuncts, we talked about these. Airway adjunct is something to just help you maintain the airway. They're nothing that's going to remain in place for any long period of time. What's the purpose of the OPA? That stands for oral pharyngeal airway. What does it do? Keeps the tongue in position. It keeps it out of the way, pulls it out from away from the back of the throat. What is the NPA, the nasopharyngeal? What does that do? It just basically leaves a little space open. It doesn't impact the tongue, unfortunately, but it does provide an airway to the back of the throat. Which one of these would you use for a profoundly unconscious patient? The what? The OPA. Yeah, because if you put that into a patient who is just sleepy, what's going to happen? Yeah. The bad thing. They're going to start gagging and throw up all over you. What kind of patient would you most likely use the nasal airway on? Not head trauma or face trauma for sure. Do what? Yeah, if they have a gag reflex, or if they've got some level of consciousness, they may not like you to put that in, but it's important that you try to get one in. Okay, rules for using airway adjuncts. Only use the OPA in a patient not exhibiting a gag reflex. That means if they got a gag reflex, you're pulling that thing out. If they are talking to you, are they going to accept an oral airway? No. Anyone, I can put one in one of your throats. Let me try this on you. Oh, you were sleeping? Here, let me try that. I don't think so. Open the patient's airway manually before using the device. Yeah, I could have thought of that. Make sure you don't push that tongue down their throat. Remember we talked about that last week too. Have your suction ready. Even those nasal airways, you know, they don't commonly produce a gag reflex, but it may just freak them out so bad they just throw up all over you. You know, they may already have a little nausea going on. So always have your suction ready to go. If they start gagging on the OPA, the oral pharyngeal, go pull that thing out right away and get ready to turn them over so they vomit somewhere else. Make sure you keep a proper head position even after you put the adjunct in. Now, know that once you put an airway in, there's a chance your patient could regain consciousness. So your patient's unconscious for who knows what. Say a coma of unknown origin. I think that sheet I gave you last week. Remember I gave you a sheet of abbreviation? Remember that?
You didn't give us the sheet of
Must have been the morning class. Remind me to do that next week. I'll give it out with the documentation. Anyway, so I'm getting ahead of myself. They may regain consciousness. Say you put an OPA in, all of a sudden they start, give it this number. What are you going to do? Yeah, I'm taking that baby out right away. I hate vomit. Always have your BSI on because I hate vomit. We saw these the other day. How are you going to size the OPA? From, like you're on the phone? Yeah, just about like that. It's in the mouth. It's going to be from the mouth to the ear. The MPA is going to be from the nose to the ear, pretty much. Now, I learned to the tragus, which is this little bumpy thing right here. Some places say it's just to the earlobe. It doesn't really matter. You know, it's a difference of maybe 1/4 of an inch. If it's too long, what's going to happen? Yeah, it's actually going to block the airway. It may stimulate their gag reflex a little bit more. If it's too small, what's going to happen? Nope, I just swallowed that. Here we are measuring it. Now, I think your textbook talks about opening the mouth when you have to insert this. I don't care how unconscious they are. I ain't putting my fingers between their teeth like that. So, you know, if you tip the head back or do the jaw thrust, you can get in there to put your OPA in, but don't be putting your fingers in there. Now, there are a couple ways that you can insert that OPA. Remember, I showed you that you do it upside down, slide it in, and then rotate it. But if you have a tongue depressor where you can grab that old tongue like this, you can put it straight in. Because remember, the reason we flipped it over was so we didn't push the tongue down there. But if you've got a tongue depressor, you can hold that tongue down and slide it in straight or to the side, either way. Whatever works best for you. OPA, you're going to insert it till it meets resistance, then you're going to flip it around. The flange stays against the lips on the outside, right? Remember that little picture? And then watch your patient. The nasal, remember it's a soft, flexible tube. It also comes in sizes. Now they're cut to be used in the right nostril, and if the right nostril fits okay and you can get it in without a problem, that's usually the better one. If not, you can put it in the left. It might be a little bit smaller, but your first choice would be the right side. Okay. You can use this usually with a patient that has an intact gag reflex. So here we're talking about semi-conscious patients or patients that you're concerned that their airway may occlude. What does that mean? The airway may become blocked, exactly. Can you think of what might cause that? Do what? Yeah, if they're going unconscious or something. What could block the airway and you put a nasal in? Somebody that's conscious and they're looking at you. Yeah, anaphylaxis, anything that could cause swelling. For example, if they've been in a fire, they've breathed in some superheated gases, that's going to cause swelling in there. Or a severe allergic reaction that's going to cause swelling in there. So the nasal pharyngeal airway might be all that's going to leave a space open for you. Did I say something wrong? Okay, all right. Wouldn't be the first time. Now, if your patient if you notice cerebral spinal fluid in the area, you don't want to use a nasal. They have some textbook concern that we're going to plant a nasal airway up in somebody's brain. It's never happened. They have no documentation that it's ever happened. But the fact that it could, I guess, in some incredible circumstance, work its way into the brain. It's a very thin bone between the back of the nose and the brain here. So if you have a break there, if you have a basal skull fracture, you could possibly slide something through there. But as I said, it's never happened, but it's just, gosh, what if? But you'll recognize that because you'll notice some clear fluid in the area. Like you might see blood coming out of the nose, but it's thin and looks watered down. Where's that water coming from? More than likely it's cerebral spinal fluid. So if you notice that there's clear fluid or thin looking blood, then you may have cerebral spinal fluid in there. We'll talk about that much more when we get to the head injury chapter. Talking about this, nasal airway, you can see how they're measuring from the nose to the ear. Remember we said you lubricate it very well. And what type of lubrication? No Vaseline?
No petroleum.
No petroleum-based products. So they're going to be water-soluble, water-based products. And you lube it up really, really good. Where do you put the bevel? You know what the bevel is? The little slice edge? To the wall, to the septum, to the inside of the nose is where that's going to go. And you gently just kind of work it. Now, if you're meeting a lot of resistance, you stop, get another one, and try the other side. But if you start doing this whole, grinding motion here, there's a good chance you're going to damage the nose, cause a great deal of bleeding. Your patient's probably going to choke to death on all that blood. They're going to get an infection, and if they survive, they're going to hunt you down. They're going to be so mad. Suctioning, talked about suction, talked about the suction machine. The purpose of suctioning is to what? Keep liquids and junk out of the lungs. Keep them from aspirating. Aspirating means they're sucking stuff into the lungs. It's never a good idea. Remember we looked at the parts of the suction unit. We had that throwaway canister. Throw that away. It's disposable. We've got the tubing. The tubing is disposable. We've got different suction tips. Remember I was showing you the hard suction tip. What's that called? The Y word. Yonker. Yeah, like Yonkers, New York. Oh, it's Yonkers, I guess. Yeah, a Yonker tip or tonsil tip or hard suction. I thought you were putting it in your ear. We were going to talk. Okay, good. Talking about hard suction and you're sticking a pin in your ear. It scares me. Of course, you got to have a suction source. We have one that looks quite a bit like this that I couldn't find the other night. I asked the other guys about it today. We're still looking for it. This is onboard suction. There'll be something similar to this at the hospital, hangs right on the wall, or in the ambulances, they've got one that hangs on the wall too. And then it'll create suction for you. It usually works a lot better than the portable, but portable's okay as long as your battery's good. Your suction device must have an air intake of at least 30 liters per minute at the open end of the collection tube. So that means without that suction point on there, if you were testing that, it's got to be sucking at least 30 liters per minute. So it needs to be a pretty serious suction. It's got to generate a vacuum of at least 300 millimeters of mercury. So when you clamp that tube down, the pressure that builds up in there, the suction pressure, should be at least 300 millimeters of mercury. So that's quite a bit. This is a Yonker tip. Now, if you had some big old chunks, and this little Yonker tip's not going to get it, it looks quite petite in this picture, doesn't it? It wasn't that small when we were looking at it. You can take that end off and just use the tubing. The end is going to be quite a bit larger. Now, I wouldn't be like feeding that down the patient's throat. Let's don't go there. But say they're laying on their side and you're trying to clean that out. You can pop that end off and just suction right around here in their mouth. But don't stick that down the back. Next thing I know, I'm going to see it coming out of other orifices. What'd you tell those students? They could stick that suction catheter down to their navel? No, I didn't say that. I didn't say that, remember? Everybody hears that. I didn't say that. Okay, you suction only as far as you can see. That means you can only put that tip as far as you can see. Unless you're really good, I know you can't see down those little curves of the tongue. You see in, but you can't see past that point. So you only go as far as you can see. Now if you're standing over the patient, got the airway open, you got a little bit better view, but you still can't see around those corners. So if you can't see it, you're not putting it there. Do not lose sight of, what is this word? What exactly does that mean? Distal means further, like distant. Yeah. The tip end of it, if you can't see it, then it's in too far. If you stick that thing in there and give it this little thing, then you're going to generate, or you're going to stimulate their gag reflex, and we don't want that. And the other thing here, anybody have an idea what this is, vagal stimulation? Okay, some of you guys have had AMP, you know, the cranial nerves, the vagus nerve. Yeah, so you may stimulate the vagus nerve here. What does the vagus nerve do for you, those of you that had that AMP? If you guys are all rested up like this, that's a vagal response. That is your parasympathetic response. So if you've got a patient that's already bradycardic, what's that? A slow pulse. Brady means slow. So if it's a slow pulse, and now you stimulate their vagus nerve, what was a slow pulse at 50 is now a slow pulse at 35. Have you helped your patient? Now, children are much more apt to have a vagal stimulation than adults do. However, just know that if you start poking around in there, you may send your patient into cardiac arrest. It doesn't happen very commonly, but just be very gentle, place it where you can see it, suction coming out. Okay. Oh, I mentioned using the suction catheter, the little flexible tube, without the tip if you need to. Now we have a, what we'll call a French catheter, and I'll have one tomorrow. French catheter is a very small, flexible tube, and we would use that for a pediatric patient, you know, to suction the nose if we needed to, or suction around the mouth, say an infant in particular, because the large, hard suction can be large and hard, so sometimes they're not appropriate. But the little soft, flexible tube, we can use those down the endotracheal tube. If the patient's intubated, we may use that to actually suction the tube. So that's something you may be able to do.
What type do they use when they suction out the lungs?
They're going to use a French tube, yeah, just like that, like I just described. Can be used for suctioning the nose too if you need to. Come in different sizes. We call them French. The larger the number, the larger the catheter. And that's opposite from when we talk about IV catheters. You can't, with the flexible catheters, you're not going to get anything big. You're going to get, you know, very thin solution only. They get knotted up sometimes. But if you got something thick, you got to use either the yonker or take the tip off and just use the tubing itself. For the flexible suction catheter, you're going to measure that very similar to the OPA. When you put it in the patient's mouth, it should equal the distance between the corner of the patient's mouth and the earlobe. So if this is your measurement, you'll take your suction catheter and you'll figure from the end to about however far it is from here to here, and that's all you're going to use. You're not feeding this down the patient's throat, okay? Because where is it going to go if you do that? It's going to go in the esophagus because the trachea is hard to hit. So if you've got a soft little tube and you're feeding it down, pretty soon you're sucking up what? Stomach contents. That we don't want. So you measure it off here, and that's about the amount of tubing you're going to use. And again, just as far as you can see. Don't be feeding it down anywhere. So then measuring. Good job, guys. Anytime you're suctioning a patient, you run the risk of stimulating their gag reflex. When that happens, what happens? The bad thing happens. So make sure you've got your gloves on, you've got a mask, you've got something covering your eyes, eye protection. Like, you know, I know you think this is really geeky, but all it's going to take is somebody throw up on you one time and it's splashing in your face. You're going, ooh, why didn't I wear a mask like she told me to? Why didn't I wear eye protection? I hate vomit. As I said, your book says suction no more than 10 seconds. Some textbooks say 15 seconds. So given a choice of that spectrum, if you've got 10 seconds, 25 seconds, 30 seconds, and 50 seconds, which one's going to be right? 10. Okay, good. If it says 15, 25, 30, and 45, which one's right? Okay, just checking. If you suction too long, you may cause them to become hypoxic. You can actually suck the air right out of their lungs. So you don't want to do that. You start causing them to be hypoxic, or you stimulate their vagus nerve, you may make them bradycardic. If the patient vomits for longer than 10 seconds, continue suction. I'm not sure what that is. As I told you, make sure you place the suction catheter and suction on the way out, not going in. Hey, keeping the airway open. Sometimes, as an EMT, you don't have the ability to keep their airway open. You can keep their head back, you can do the jaw thrust, you can ventilate, but you can't control edema. Sometimes you can't control a blocked airway. You can't control trauma that's blocking the airway. So sometimes definitive control is outside of your skill level. So in that case, what are you going to do? Help me, help me. Call for backup. Get an ALS unit where they can do something more with the patient. They're going to have medications. They've just added some new meds, some new procedures to the ALS, to the paramedic level. I told you guys this the other day. They're going to allow them to paralyze patients, give them medications to paralyze them. They're going to be doing cranks here pretty soon in this state. Other states, some of them have been doing it for a while. So they are going to have more procedures that they can do to help manage the airway. And if you guys go on the program, you'll get to do that too. You've got to be able to quickly recognize respiratory failure. If the patient's having airway failure, meaning they can't control their airway, you've got to be ready to assess it and manage it as quickly as possible. It may be calling for ALS. ALS stands for Advanced Life Support. For instance, the advanced EMTs, they have what we call a supraglottic airway, which is an airway that they insert. It doesn't actually go in the trachea like an intubation, but it does go in the airway. It does a pretty darn good job of providing an airway for your patient. It may mean you're just going to haul butt to the closest hospital. If something happened right here, are you going to wait here for an ALS unit, or are you going to like make tracks over to East Alabama? It's only 5 minutes away, isn't it? About that? Yeah. In that case, I might just make tracks to the closest hospital. If you are not able to manage an airway at the EMT level, what advanced resources might be available to you? Yeah, the advanced EMTs can do what? They can put an airway in. The paramedics can do what? They can do a crike. They can crike it, or they can do an endotracheal intubation. So yeah, you've got choices for you. ALS will be able to paralyze the patient. And I know you think, why would they have to paralyze a patient? Do we have that conversation in here already? If you've got a patient with a severe head injury, oftentimes you'll find that they clench their teeth down and you cannot open their teeth. And if you can't open their teeth, you're not going to be able to intubate them. Patients with severe head injuries, the brain starts to swell and their respirations become very irregular or not at all. So the paramedics can paralyze the patient, and once all that, the muscles are relaxed, then they can pass a tube through there. Okay, special considerations. If you've got a patient with severe facial injuries or head injuries, you may have a hard time, say, if their cheekbones are shattered. Are you going to be able to press on that to open the airway? If they've got a cut like this, like a horse, you know, they got a thing in here and it's been cut like this, how hard is it going to be to get a mask seal on that? It's going to be pretty hard. So there are going to be times where the facial injuries are going to be so severe that you're going, God, how am I going to make this work? But you know, that's part of the fun, not fun, but it keeps this job interesting. You have to problem solve it sometimes. You know, see if you can't figure out a way. We got duct tape, don't we? Okay, if you've got the Joker smile here, I can put some duct tape here and some duct tape here. I might be able to get an airway there. So, sounds silly, right? Hey, if it works, you saved a life. It's important. You may have to suction much more commonly. Does that sound funny? Duct tape on the face?
Over a cut?
A severe cut, where it's ripped
Maybe
here
severely
all the way
bad.
to the ear. Huh?
Maybe that needs to help.
Oh, they're probably dead. And let's see, would I want to be dead or have a piece of masking tape on my face? Okay, who wants the masking tape on your face?
Oh,
Give me the masking tape. But not for you, Emily. It would really mess up your looks. Okay, if you've got a patient with a lot of bleeding, you're probably going to have to suction a lot. I already said this. You may, if they've got an object in your airway, you know, a choking thing, you may have to do manual choking maneuvers. If they're choking on their teeth, if their tongue has been severed, they're choking on that, you know, you may have to turn them on their side and get your hand down in there and scoop some of that stuff out. You may have to use abdominal thrust to get air from down below pushing that out. So you're going to have to be creative. What do you do if you're still unable to clear the airway? Yeah, say they're on their way. What are you going to do in the meantime? What do you do if you've got an unconscious patient and they got a blocked airway? Okay, we all read that part, I see. I know you're going to see that on your test on Tuesday. Y'all scare me. Okay, dental appliances. As long as the dental appliances are fixed in place and they're secure in there, they really help you get a seal. If they're loose, they may interfere with the airway. If you've got Granny who's got dentures in here, and if they fall out, you know, they're not there anymore, it's hard to get a seal without teeth because they don't have that much structure. If they've lost their teeth, they're gradually going to lose more bone structure too. So it's a lot more difficult to keep an airway seal. So if their dentures are in and they're secure, leave well enough alone. If they're loose, you run the risk that they're going to fall out and block the airway. So be prepared to remove those. And if you do, make sure you remember where you put them, right? Remember we talked about that? When they bury Grandma, they're going to want her teeth in. Okay. We're going to talk at length about pediatric patients and their airway later. So we talked about the shape of the airway already in here, didn't we? Remember? The pediatric airway is funnel shaped. The adult airway is just the opposite. The smallest part of the adult airway is what? The top, the glottic opening. The smallest part of the pediatric airway is C for child? Cricoid, that's right. Yeah. Shape of the head, we talked about how that interferes with their airway, right? Because it's got a big old head, throws their head forward, got the big old tongue. And they have underdeveloped chest muscles. So what is their major way to breathe? Their major muscle, so to speak. You notice that they're abdominal breathers more. They're using their diaphragm and they're using their abdominal muscles, which are not very strong either, in order to help them breathe. But the younger they are, the less muscles they're going to have in between their chests to make that work. Don't hyperextend the neck of a kid. That's what I was talking about, putting the head back. With an adult, I mean, you're going to put that thing back as far as you possibly can. The further back it goes, the straighter that airway is. With a pediatric patient, you do it back like that, it's like a Pez head. You block the airway. With kids in particular, when you're using a suction tip, that rigid tip, make sure you're very careful that you don't touch the sides of the airway. Go straight in, close to the uvula, that's a little hanging down thing. Keep it straight, keep it where you can see it. If you start touching the back of the throat, they're going to get that, they're going to vagal down. That's what we call it when the vagus nerve is stimulated. But they will become bradycardic very, very quickly and may lose their pulse and stop breathing all at once. So don't touch the back of the airway with a kid. Keep it clean. Make sure you've got your PPE on. Continuously reassess their airway. It is dynamic. When I say the D word, we're talking about dynamic. Dynamic means what? It's constantly changing. It's like the sea. It's constantly changing. Airway management should start simply and become complicated only if necessary. 95% of the time, airway management is a basic life support. That means keeping the airway clear with suctioning, keeping the airway open with head position, a good mask seal on the BVM. That's what we're talking about 95% of the time. And that is the thing that trips up more providers than anything out there. Paramedics, they get on their test and they want to intubate. It's not always indicated. You feel like, oh, I can't manage this. Yeah, I can. 95% of the time, all it is positioning, suctioning, getting a good seal, and providing the oxygen when it's necessary. That's most of it. Explain why care for the airway is the first priority of emergency care. Can't breathe? We die, right? Good, we got that one right. Describe the signs of an inadequate airway. How are you going to recognize the patient has a compromised airway? Not talking about they're breathing inadequately, but a compromised airway. They what? Airway sounds. You may hear stridor. What else? You may see they're hypoxic. Of course, that could mean a lot of other things too, besides just an inadequate airway. How would you recognize that it's a tube issue? If you don't see any chest rise, no air's getting in. So yeah, you want to watch for chest rise. That means that the airway is probably not clear. For a pediatric patient, it may mean it's open, they're just not able to get any air in. But remember things we talked about early on? Some other sounds? All right, if you have gurgling, the airway's not open, you've got fluids in there. We talked about stridor, snoring respirations. Well, hoarseness, yeah. Raspy sound, all those would indicate that you've got an inadequate airway. Explain when the head tilt chin lift maneuver would be used. What kind of patient? Medical patient. Usually no trauma indicated. Would you use it for anybody in this room right now? Who said yes? We're going to do it on you.
They were like adults here.
Okay. Well, let's do it on you. That's going to be your job, Seth. We'll do that on acting, okay? Ready? Huh? So what type of patient are we looking for here? Yeah, unconscious. A good word for that, rather than unconscious, would be this. Has anybody ever heard that word before? Obtunded Anybody ever heard that before? I won't embarrass you. Just kind of go. Obtunded means they're not totally unconscious, but they are getting close to it. So anybody that is obtunded, which may mean they're close to being unconscious, but they're not totally unconscious, they have a completely altered mental status. There's a chance they're not being able to control their airway properly. So anybody that's obtunded, you would do a head tilt chin lift. So like if you were totally passed out in here sleeping, you wouldn't be unconscious, but you're probably obtunded, you know, until we kicked your chair really hard. When would we use a jaw thrust? What kind of patient? Trauma patient with the possibility of a spinal injury. Now, if I broke my leg, you know, that might be a trauma. You know, if somebody stabbed me in the leg and it fractured my femur, that's a trauma. Would you need to use a jaw thrust? No, because there's really no indication of a spinal injury. So, trauma, but in the presence of potential spinal injury. Okay. On arrival at an emergency scene, you find an adult female patient with gurgling sounds in the throat. Okay? An inadequate breathing, slowing to almost nothing. How do you proceed to protect the airway? Number one, suction. Number two, open the airway. Assure ventilation, you think? Okay, how are we going to assure ventilation? Or assure open airway? Measure, yeah, NPA or an OPA, that's right. It doesn't say we have a trauma. Do what? Yeah, what are those things? So yeah, some airway adjunct. And now what? Are we going to put her on a non-rebreather, a nasal cannula, or a bag valve mask? Should be right on this. Bag valve mask because, what are the key words in here? Slowing to almost nothing. Yeah, she's obviously breathing inadequately. So we will suction, we will open the airway, we're going to use an airway adjunct, then we're going to bag her. Good work. When evaluating a small child, you hear stridor. What does this sound tell you? Upper airway obstruction. That's right. What are your immediate concerns regarding this sound? Choking. Yeah, got a toy or something in there, most likely. You're right. When assessing an unconscious patient, you note snoring respirations. Should you be concerned with this? And if so, what can you do to fix it? Probably the tongue blocking the airways. How are you going to fix that? Yep. First we're going to open the airway with, we know they're unconscious. Do we know it's a medical or trauma? Okay, if it's a medical patient, how are we going to do it? Head tilt chin lift. If it's a trauma patient with possible cervical spine injury, the jaw thrust, that's right. And then we will put in an airway. If it's a possible head injury, which one of the adjuncts would you use? Probably an OPA. What if they have a gag reflex? Probably a nasal. Yeah. All right, don't go because I want to play my lung sounds for you. See, you thought I forgot. Don't you like that picture? I just love that. Yeah, that's some kind of tie.